Hello everyone. Happy holidays, Merry Christmas. Today I'm going to talk to you guys about waveform capnography and how it can be used to assess how well a patient is ventilating or breathing and how it is able to show you different things when it comes to treatment. So first of all, what is it? Waveform capnography is a way to assess ventilation. It represents the amount of carbon dioxide or CO2 in exhaled air. And capnography consists of a number and a graph. So we're going to take this pencil right here. I know it's small, but this little orange thing right here and this graph right here are the things we'll be talking about. So the capnography is this graph, and the capnometry is this number here. And it could tell you respiratory rate, it's small, the end tidal CO2 in millimeters of mercury, and then obviously this graph. So how do we measure it? So you can measure it via a nasal cannula. The bag valve mask attachment when using an advanced airway like an eye gel, ET tube, anything like that. And then there's also colorimetric devices. I know they're making their way out. This one right here is the colorimetric device. I don't see it used pretty often. The standard is usually these two right here, which is what I will be talking about. But if your agency does use the colorimetric, that is an option. So what are the normal ranges? So the normal range for an end tidal CO2 should be 35 to 45 millimeters of mercury. It can go higher, it can go lower. The highest I've seen is about 60, 70. I've seen lower in sepsis patients. So 35 to 45 is the standard. If it's higher than 45, that means your patient is hypoventilating, they're in respiratory distress, or an airway obstruction could be occurring. If the number is displayed as lower than 35 millimeters of mercury, can indicate poor perfusion, hypovolemia, and sepsis, among a few things. So waveforms are very important. They can show you how the patient is ventilating. It is a graph. It is a picture of how their breaths are. I'll show you in the next slide. They should be a nice little box. If they're not in a box, that was my dog yawning. I'm so sorry. If it's not a box, then we are having some issues. The waveforms and the numbers can show ROSC during a cardiac arrest, impending bronchospasms in the asthma patient, dislodged endotracheal tubes, how adequate CPR is, a bunch of things. So here we have the basic waveform. So we'll start at the bottom with your inspiratory baseline. Let me change that color here somewhere we can see. We have the inspiratory baseline here, where obviously our inspired CO2 is 0. And then when you start to exhale is right here. And that is called your expiratory upstroke. So you're in that plateau where you can't breathe in anymore. And then this point right here, that end expiration where you're starting to breathe in again, is that downstroke. And this little end expiration right here is the end tidal CO2. And that is what we are going to try to look at. The next slide here shows many different waveforms that you can see, so we'll hit on a few of those. So the first one is the normal capnogram up here at the top. We'll mark it here. So it should be boxy, between 35 and 45 up here. You can see it's just this nice little, it's not sharp, it's a nice in and out type of breath. It's not short, it's not long, it is just a nice little box. Next, we have what I learned as the shark fin. So you can see how it looks like a shark fin here. It's kind of angled and it's a sharp downstroke. Angled and a sharp downstroke. Kind of looks like the jaws fin. Usually the end tidal CO2 is greater than 45. And this is in your bronchospasm, asthma patients, other causes COPD, foreign body. It's just that type of breathing. Next, this increased end tidal CO2, that hypoventilation. So you've seen how up here, I'll mark it in red, how there's not a lot of space between these breaths here. And then down here on this third one, you can see this long pause between breaths. So that means the patient is not breathing in as much, just maybe 4 to 6 breaths a second, or a minute. I'm sorry, 4 to 6 breaths a minute. Your end tidal CO2 is going to be greater than 45. It's, something you should look at to see if you need to be bagging this patient, especially if they're hypoventilating to less than 8 breaths a minute. Next, we have the hyperventilation. So your end tidal CO2 is going to be less than 35. And you can see here how the time between breaths is very short. So they're breathing in, just, they're not blowing off that CO2. And of course it says over here, increase in respiratory rate right here. It can also mean increase in tidal volume. Metabolic acidosis, that's a good one for DKA. With Kussmaul's respirations and things like that, that'd be a good one to know. Up here on the top right, breathing CO2, not something I see too often. Obviously your end tidal CO2 is greater than 45 because you're rebreathing that CO2 in. It's the inadequate inspiratory flow, partial rebreathing, insufficient expiratory time. So it's just because you can see where right here how it's not a straight line. It's like they're kind of breathing in like that. Next, the Carrere cleft. That's more for mechanically ventilated patients, especially if they're on muscle relaxants. So if you have someone that's intubated during surgery, and you see this Carrere cleft, which is this right here, it means the patient is trying to breathe on their own, and you should reevaluate if you need to sedate them more. And as it says right here, depth of the cleft is proportionate to degree of muscle relaxants. So if the patient is starting to wake up, obviously you need more muscle relaxants so they don't try to fight the tube. Cardiac arrest here. I know you all can't see it, so I'm going to write it here. I want to say 20 is normally where it's at. So 20, like that. You want to keep it about 20. And you can see where it says rescuer change right here. So if you're doing CPR and you notice your end tidal CO2 is normally at 18 and suddenly it swaps to 10, you need to reevaluate if your rescuer is doing adequate CPR. If they're not doing adequate CPR, they need to be changed out because obviously the patient is not getting the cardiac output that they need. And then I know my camera's somewhat in the way, but I'm going to circle it. This right here, return of spontaneous circulation, ROSC. You'd be able to tell, if you're doing CPR and suddenly, it's at 20 and you get an increase to 45. The patient is starting to breathe on their own, and you need to evaluate for ROSC. When to use it, I would do it anytime you're putting a patient on oxygen, anyone with difficulty breathing, especially if you have a patient with COPD, CHF that wears oxygen. It's not going to hurt to just go ahead and put them on end-tidal CO2, especially if they're going in, they might have fluid on their lungs, even though their chief complaint is something else. In case respiratory needs to get involved, it is something when you give a report, you can give the doc, like, hey, I have a patient, history CHF, where's 2 liters of oxygen at home, they're needing 3, their end tidal is 50, 55. It'd be useful for them to know, to realize that they are still holding on to that CO2. In cardiac arrest, it can show if the chest compressions are being performed adequately, if you need to switch rescuers. It can show ROSC, plenty of things, especially with the graph nonetheless. And then how do you use it? So like any basic nasal cannula, attach the green adapter here to your oxygen source, set your flow rate. This orange thing is what will screw into the monitor on the LifePak 15s. It's in the top left-hand corner. It's got a little door. Flip the door up, just screw it in. Don't over tighten it. Place the nasal cannula on the patient. This little bubble thing is what will measure that CO2. It'll display on your monitor. Now you will, when you have the monitor, I'm not an artist, but we will try to make a drawing here. So on your LifePak 15s, you got the screen and there's 3 lines. You got your little pulse rate up here, not a great pulse rate, your SpO2, which is normally in blue. And then normally it's like another kind of pulse rate on this third one. So you're going to use the scroll wheel, scroll down to this third little box, hit the middle button, and change it to end-tidal CO2. And then it'll show up with your nice little waveform over here. And then it should display, obviously, the number and things like that. And then for the BVM attachment, you attach one end to the BVM, the other to your iGel or your ET tube, and screw it into the monitor as well. Like I said, this is something that should be used on every patient with difficulty breathing, cardiac arrest. I think it's something that is a good quantitative thing to show how well your patient is breathing. And I hope you all have a Merry Christmas and Happy Holidays.